Dr. Kevin Gibbons is the Physician Director of Surgical Services at Buffalo General Medical Center and the Gates Vascular Institute. He's also the Chief of Neurosurgery for Kaleida Health. Doc, thanks for joining us today.
My pleasure, Mike.
So winter is here. The spike that everybody predicted for COVID is also here, and that has had some collateral damage on your world. So let's get in and talk a little bit about surgery. So recently the state came down with a new directive to take elective surgeries out of hospitals. If you can, let's just start there for our viewers. What's the difference between a regular surgery and elective surgery, or what some may call planned surgery?
So in the old world, or the old meaning of the term elective, we thought of surgeries as emergent, to be done right now, urgent or add-on, to be done today, and everything else was elective. But what that really meant is scheduled, meaning it was planned, you were assessed by your doctor beforehand, all the testing was done, you came into the hospital typically the morning of surgery. So that's the old world of elective. Now that we're trying to prioritize surgeries as we're challenged with both staffing and potentially bed utilization issues, what elective means is really optional. So if you are, for example, having plastic surgery, that's very optional. If you've had a knee that's bothered you for 2 years and you finally said enough, well, you may have to wait 2 or 3 months. That's an option as to whether to have surgery, and it's optional as to when to have surgery. If I see someone in the office today with a brain tumor, I'm going to schedule them next week. We used to call that elective surgery. It's not elective. They need to have the surgery. But the timing, it is a time crunch.
So this is the second time around this has happened in the Western New York community. This happened in the late spring and carried on through the summer. So it's obviously probably from a logistics and operations standpoint, really impacted the physicians' calendars, their lives, but also the patients. So as you go through this type of process or this new directive, how do you guys figure out what cases go right away, what cases can wait for a week or two? Are you still dealing with patients from back in the spring who had to have their procedure rescheduled?
There is some of the backlog that has not yet been taken care of, particularly in terms of joint replacement surgery, some bariatrics, things of that sort. So we have to assess the patient. We have to take the information the surgeon gives us, and there's a scoring sheet that we've worked on with guidance from the state to help really clarify the people who have medically necessary, time-sensitive surgical needs, so we can get them taken care of. These are people who can't wait safely 2 or 3 months to get their surgical needs taken care of.
So that would be those who it's really taken a toll on their body or their health or their psyche, those who can't put those types of procedures off, correct?
Correct.
So fast forward, again, it's December, we're in that second wave. If you're someone who, recently received a diagnosis that they do need to go through surgery, what can they expect? How are they dealing with this in the midst of all this COVID and now this new directive from the state?
So we have to deal with COVID, but we also have to take care of the members of our community. And that means they need to be in communication with their doctors, quite often through a telemedicine platform. Diagnostic services such as MRIs and CTs and labs are open. We don't want people to delay necessary medical care. And then the doctor and the patient will get together and help determine how urgent the condition is. And then we'll take that information and we will prioritize and we will get them done.
So a subtle message here of don't avoid going to the doctor or don't avoid surgery.
Please don't avoid going to the doctor. The number of missed cancer screenings is very concerning. The fact that during the peak of COVID in the springs, the number of people having heart attacks went down significantly. Well, it didn't go down significantly. They just didn't come to the emergency room quick enough. So we really encourage people to take their health seriously and to be in communication with the doctors. It's quite often done through telehealth now, through a phone call or video visit. It can be done safely if you have to go to the doctor's office or the hospital. So we really want our patients to get the care they need.
So again, on that backlog of cases, or those who may have put off their health or may have been forced to put off their procedure, talk about it when you see or hear about the cardiac cases, or you mentioned oncology. Give some examples and discuss why some of those things are extremely important right now in terms of planned versus elective versus emergency surgery. Why is that important to make sure that as an organization or if the surgeons are really triaging these cases?
There are certain things that can be delayed with some inconvenience to the patient, and maybe their pain or discomfort goes on a little bit longer. But there are certain things that a delay of a month will result in a worse outcome, will increase the degree of surgery that they need, will increase the potential risk of complications. So we really need these patients to be assessed, and we will work very hard to get them taken care of. I take care of patients with spinal cord problems and brain tumors, and I had some patients who were afraid to come in long after the peak of COVID in the spring, and their care has been affected by that delay, partially out of fear. And part of our job is to give people the assurance that we will get them taken care of.
So, Doc, as a physician leader, but also a surgeon, you probably see both sides of the story or the issue in terms of the need and want to continue to perform surgeries, but also that takes up bed capacity, that could take up employee capacity. From a public health perspective, maybe explain why this issue comes to light when there's a peak like this of COVID. Why is this such a big deal? And why are all the headlines about no more elective surgeries? Put that in air quotes.
So people have to realize that our hospitals in normal times are very busy places, and that we don't sit around with half of our beds empty. The Buffalo General Medical Center, the hospital I know the best, runs very close to capacity in a very efficient manner. Well, suddenly, if you add 100 patients to a 500-bed hospital with COVID, you have to make adjustments to care for those patients. So we do have we do have to make adjustments, and the surgeons and the patients in this community have made those adjustments. Our surgery schedule is probably currently now just under 2/3 of our total of our normal on a daily basis. If the needs of this community go up, our surgery schedule will become lighter. We will do less cases, but we will adjust accordingly so that all the patients in this community get taken care of. We have the ability to greatly increase bed capacity and ICU capacity. We have physicians trained and retrained or repurposed to take care of patients in the critical care ICU setting. So everyone worked very hard. We have the capacity in this community to help take care of our fellow citizens. I want to encourage them, though, to do their best to avoid getting sick, social distancing, wear a mask, no shouting or singing, protect your healthcare workforce. We don't want them to get sick. We want them to be able to take care of us.
Doc, that's great advice. Extremely helpful information, as we're trying to deal with this pandemic. Appreciate your time today. Joining us here on Medically Speaking. Stay safe and hope to see you soon.
Have a great day. Stay safe.